हेलो हेलो हाँ मैंने शेयर कर दिया है। ठीक है, अब डाल दो। ओके ओके ओके। मम्मा स्ट्रीम कर रहे हैं बस। हाँ हाँ कोई नहीं, कुछ नहीं कह रहे। Hello everyone. Thanks for joining. We shall be beginning shortly. If I am audible, please reply whether you can hear me or not. Thank you so much. We shall be beginning in a few minutes. तो आज हमारा topic of discussion is CVS physiology, and it's very crucial that we understand CVS physiology before jumping on to your CVS medicine, that is cardiology proper. तो आज मेरा main motivation is to work with you all guys and just आज discuss करते हैं CVS physiology. And I have about 170 slides, so we'll be having it in a two-part session. So today is part 1. Let's see आज हम कितना cover कर सकते हैं. So just telling you something about the lecture layout आज के लिए. तो mainly we'll be studying about the properties of the cardiac muscle पहले. Going over its action potential, then we'll discuss about the automaticity of the heart. That will be discussing mainly the जो भी हमारे electrical that is your SA node or your AV node, all of these things we'll be discussing today, as well as the transmission through the heart. Then we'll moving on to your some brief discussion about your pulse and your blood pressure. And पर आज का जो main session है, that's about cardiac output. And mainly the factors regulating cardiac output, the homeometric and the heterometric regulation of cardiac output. We'll be discussing about the factors affecting heart rate, and if possible, then we might discuss about the cardiovascular regulatory mechanism as well, whether it be the immediate, long-term or short-term regulatory mechanisms. So we're going to start at 10:02. I'm going to wait for 2 more minutes for people to join. And I would suggest that CVS physiology is very important before we start any unit concerning your heart, whether it be your CVS pharmacology. If you have a very good understanding about the action potential and the phases of the action potential, you might be able to understand very well the antiarrhythmic drugs which work. Same goes for your different properties of the cardiac muscle as well. That is your contraction, your stroke volume, and diastolic volume, the different phases of the cardiac cycle. Everything works in synchrony. So आज का हमारा main session is to brush all of that up, and let's just try to revise all of CVS physiology in maybe 1 or 2 sessions. So let's just wait for 1 more minute, then we'll start shortly. Thank you everyone for joining. And if there are any questions from the previous section, or your if you're having questions about within the session as well, please feel free to ask them. I'll try my best to answer them. Even if I don't have the answer abhi, I'll try to look it up and get back to you very soon. I think we are all learners here. We are learning something from someone at some point of our lives. So let's just continue to do that. All right, I think we should start right now. It's 10:02. So thank you everyone for joining again. So let's just start with CVS physiology. All right. So the first thing that I want, that we've already discussed in nerve muscle physiology about the concept is about the striations. We know the cardiac muscle, right? So the cardiac muscle is what? It's a striated muscle. We know that, we have these striations. Just like a skeletal muscle, a cardiac muscle is also striated. And what do I mean by these striations? That I have these alternating bands of your zones that we discussed. हमने discuss किया था about the I bands, we discussed about the A bands, we discussed about the H zone, the M line, the Z disc, everything. You can look it up in the nerve muscle physiology section. But आज का हमारा main structure is about discussing the cardiac muscle in proper. So let's just see. So this cardiac muscle actually has a branch structure. Can you see? All of these myocytes or myofibrils, we can call them. They're connected via these discs known as your intercalated disc. Okay? So what are these intercalated discs and what do they do? Basically, these intercalated discs have a multiple amount of your different interacting proteins, and 2 of them might be your desmosomes, and we have your gap junctions. Abhi ke liye we need to concern ourselves more with your gap junctions. We saw the same amount of gap junctions in your single unit smooth muscle cells, and now we are seeing it in a cardiac cell as well. So that all of the atrial and your ventricular muscle, it basically contracts in a syncytium, तो हम generate कर सकते हैं the amount of cardiac output that we need. or the stroke volume that we need. So this is the gap junction, and I think you might be remembering that what are the different cell junction that we have. So abhi ke liye we are discussing about the gap junction. So we know the gap junction is made up of these subunit proteins known as a connexin, and ये जो सब connexins हैं, 6 of them, they make one connexon, and ऐसे 2 hemiconnexons, they make a pore, जिसके through we can have multiple things going in and out. That is mainly your ions. The second thing that I want you to tell is desmosomes. ठीक है? So in this cell junctions, you just have to remember 2 things. You have to remember the protein, and you have to remember the cytoskeleton with which it is associated. So in case of desmosomes, the main protein is your cadherin protein. And what is it associated with? It associated with intermediate filaments like your keratin. Okay? So let's just see what is the desmosome. So it's going to connect your intermediate filaments. In case it might be desmin, it might be keratin, or any other intermediate filaments of 2 cells. Okay? And what does it do? It structural adhesiveness ko contribute karta hai. It plays a role in tissue morphogenesis, wound healing, as well as cell signaling. So this is what I call a desmosome. We have some different proteins over here. So can you see some of these proteins? Let's just make them out. So we can see a desmocolin protein and a desmoglein protein. Okay? So ये जो part of the desmosomes हैं, they are your extracellular surface पे, right? And what about the integral membrane proteins? उसमें we have 2. We have your plakophilin and your plakoglobin. Okay? So the main ones that we have here discussing is desmocolin, desmoglein, plakophilin, and plakoglobin. All of them make up your desmosomes. Okay? Right. We discussed about that. The intermediate filament which is present in your striated muscles is mainly desmin. Okay? Right. So this is again the intercalated disc. We saw about the desmosomes and your different structural components of the desmosomes, and we have already discussed about the gap junctions in great detail. And the last thing that I would tell you is something about the fascia adherens. Why am I calling it as the fascia adherens and not your adherens junction? Is fascia adherens is very specific for your heart. Okay, so you will not have this term thrown around regularly. It's only in cardiovascular physiology do you see something known as fascia adherens. So it's only present in the heart. Okay, and what is it composed of? It's mainly composed of cadherin again. But if you see, adherens junction में cadherin was the one which was associated. That's fine. But the cytoskeleton filament is your actin. So इस case में भी fascia adherens में it's mainly present in the heart. The cadherin is the protein associated with it, and the cytoskeleton component जो है that is your actin. ठीक है? And when I talk about zonal adenins, what is that? Basically जो epithelial cells में होता है, जो उसे जोड़ता है adherens junction, जिसे हम कहते हैं E-cadherin. I think you might be remembering this. E-cadherin that we often study in multiple diseases. We might study it in lobular carcinoma in situ as well. वहाँ पे भी E-cadherin का mutation होता है. तो it mainly उसका function क्या है? It's one function is कि structural adhesiveness. But if you might be remembering, E-cadherin also plays a very important role in your molecular signaling as well. ठीक है? I would want you to go and check what is the main difference of this cadherin and what is its association with your beta-catenin. ठीक है? Right. So gap junctions we have already studied, right? We have studied कि भाई ये gap junctions are mainly electrical bridges and 6 connexins make one connexon. That's a hemichannel. ऐसे हमारे पास 2 हैं, and they basically contribute your different amount of sodium or your potassium or your calcium can come in and through all of these cardiac myocytes which are connected by these gap junctions. ठीक है? So because the gap junctions electrically couple cardiac cells, can I say that it's a syncytium? Definitely. Just like a single unit muscle cell, this also functions as a functional syncytium. ठीक है? So just remember, the large mitochondria, which is about 25 to 35% of your cardiac cells, which you only compare with about 2% in your skeletal muscles. So cardiac myocytes are having abundant stores of mitochondria, and that is the reason why they're very resistant to fatigue. If you might be remembering, when we discussed about your skeletal muscles and the nerve fibers and different things, we discussed about the different types of fibers. We discussed about the fast oxidative fibers. We studied about the FOG, that's a fast oxidative glycolytic. We discussed about the fast fatigable, and we discussed about slow resistant to fatigue. ठीक है? पर यहाँ पे what I am telling you about, the cardiac muscle जो है mainly it's very resistant to fatigue. ठीक है? Right. In contrast to the skeletal muscle, the myofibrils of the cardiac muscle cells vary greatly in diameter and branch extensively, जो अभी हमने देख लिया, and all of that accommodating the abundant amount of mitochondria which is present there. ठीक है? A very important thing is the system for delivering calcium is less elaborate in cardiac muscle cells. What do I mean by that? कि जब हम sarcoplasmic reticulum की बात कर रहे थे in your skeletal muscle cells, and we were saying कि भाई terminal cistern होता है, sarcoplasmic reticulum होता है. We talk about in those terms mainly in case of skeletal muscle only. यहाँ पे what we are talking about is कि जो अंदर का sarcoplasmic reticulum है, as compared to a skeletal muscle, it is less developed in your cardiac myocytes. So what is it dependent upon for calcium? It might be dependent extracellularly. ठीक है? So the T tubules, that you remember the T tubules, that was the transverse tubules जो अंदर की तरफ invaginations हो रही थी of the sarcolemma, they're wider and fewer than in skeletal muscles, and they enter the cell once per sarcomere. Why is that important? So they will form a dyad. Okay, we've already discussed about that कि एक T So sorry for the interruption. थोड़ा सा problems हो रही है with the stream. Alright. So we were discussing about the T tubules. हमने कहा था प्लाज्मा मेम्ब्रेन की इन्वेजिनेशंस को भी हम T tubule कहते हैं, और जो हमारे सार्कोप्लाज्मिक रेटिकुलम का एक एक्सटेंशन होता है दैट्स नोन एज द टर्मिनल सिस्टर्न. ठीक है. So ये इन दोनों को we call them collectively as a dyad, and it will enter once per sarcomere. ठीक है, once per sarcomere it will enter, and this is in contrast to a skeletal muscle जहाँ पे it enters about 2 per sarcomere. ठीक है. So in skeletal muscle the T tubules invaginate how many times? They invaginate mainly twice, as compared to a cardiac muscle जहाँ पे they invaginate only once. And what do they form? They form a dyad. हमने पढ़ लिया. Just remember the cardiac sarcoplasmic reticulum, as you again I am reiterating again and again, it is much less developed as your skeletal muscle का sarcoplasmic reticulum. Okay, right. So let's just see one more fundamental fact again. So this is the skeletal muscle we already discussed, and this is a myocardium. So what can we see as the difference? Did I tell you about this interaction? We have something known as the dihydropyridine receptors. I hope you know that, है ना? They're calcium channels mainly, and they mediate the action potential. जब ये dihydropyridine receptors खुलते हैं, they allow the inflow of sodium or calcium. ठीक है? So dihydropyridine receptors, and these are ryanodine receptors which are present in the sarcoplasmic reticulum. If I have to talk about the skeletal muscle, it's ryanodine receptor type 1. So type 1 is for your skeletal muscle. And what were they linked by? They were electromechanically linked. What do I mean by that? They're electromechanically linked. मतलब whenever this DHPR was activated, did I tell you that there was a spring sort of? I would say it is a spring type of mechanism. Whenever the DHPR is activated, it pulls the spring, it pulls the cork out of the champagne bottle, and what does that do? It allows the influx of your calcium from the sarcoplasmic reticulum into the cytosol. So this was the skeletal muscle, pakka. What about in case of myocardium? Myocardium, they're not linked. Do you see any link? I don't see it. So there's no link. The ryanodine receptor that is C is mainly your ryanodine receptor type 2. We already discussed कि जो sarcoplasmic reticulum in case of your skeletal muscles, cardiac muscles is less well developed. They might not have the terminal cistern which we talk about. ठीक है? And because there is no link, तो यहाँ पे basically क्या होगा? This is a DHPR with a calcium channel. So the calcium comes inside. Fine. Now this ryanodine receptor is a calcium sensitive calcium channel. So what do I call it as? कि यहाँ पे जब calcium bind करेगा, so this is the ligand. What is it? It's calcium. So whenever calcium binds to the ryanodine receptor, it's going to open the ryanodine receptor, और उसके through calcium आएगा. So what mediated the influx of calcium? Calcium itself. So that's known as calcium induced calcium release, CICR. So when I say electromechanical coupling that happens in the skeletal muscle, when I say electrochemical coupling because this ligand is a chemical, that's your calcium, then that is in case of your myocardium. Okay? So let's just see. So we have electrochemical coupling involving calcium-induced calcium release in case of what? In case of your cardiac muscles. And you had electromechanical coupling. That is why the DHPR and the ryanodine type 1 receptor that is seen in your skeletal muscles. Okay. Just remember, we were also talking about something known as the circa. Okay? We know this. That we had something, ये हमारा sarcoplasmic reticulum था. Once the contraction phase is over, we need to pump this calcium वापस into the sarcoplasmic reticulum. So it's going against its concentrated gradient. So obviously we need a pump. We need ATP. So what was this channel known as? This channel was known as circa. Sarcoplasmic endoplasmic reticulum calcium ATPase. Done. So this circa is usually inhibited by something known as phospholambin. Okay? Phospholambin. Right. Just remember, phospholambin is active when it is unphosphorylated. So whenever it is in unphosphorylated state, it's active. Okay? And whenever I phosphorylate this phospholambin via some kinases, we'll talk about this. What can happen is this phospholambin gets inactivated, and hence this circa gets thrown into overdrive, and hence we can mediate more amount of cardiac contractions per minute or per second. Okay? Why I keep on emphasizing about that is whenever I talk about beta receptors, है ना, हमने already discussed किया है in case of your endocrinology that beta receptors are mainly adenyl cyclase linked via the G protein. So if they're adenyl cyclase, they'll increase your cyclic AMP. They're going to activate your protein kinase A. And what is this protein kinase A going to do? It's going to phosphorylate your phospholambin. So it's going to phosphorylate your phospholambin. Phospholambin ki activity will decrease. And what will that lead to? That will lead to activation of your circa. So isn't that good? कि beta receptors क्या करवाते हैं? They basically cause tachycardia via multiple mechanisms. And one mechanism I'm saying is to facilitate tachycardia, हर contraction के बाद we need the calcium to go inside, वरना तो tetany में throw हो जाएगा ना muscle. ठीक है? वैसे तो टेटनी नहीं हो सकती कार्डियक मसल्स में बिकॉज दे हैव अ वेरी लॉन्ग एक्शन पोटेंशियल, बट जस्ट इमेजिनिंग वी नीड कॉन्ट्रैक्शंस हैपनिंग एट फ्रीक्वेंट इंटरवल्स एंड दैट फ्रीक्वेंसी वी कैन मॉड्यूलेट वाया एक्टिवेटिंग सर्का थ्रू फॉस्फोलैम्बिन. ठीक है, राइट. सो अगेन वी डिस्कस दिस. What is this known as calcium-induced calcium release? ठीक है, extracellular calcium can also contribute. Can you see? इतना ज़्यादा it is dependent upon your extracellular calcium, 10 to 25%. This was reduced in skeletal muscles. Skeletal muscles have such a very beautiful mechanism of your sarcoplasmic reticulum. उनका architecture इतना developed है that they don't need extracellular calcium. But if I place the heart in a solution, if this is my heart, and they studied in pharmacology again and again, if this is my heart and I place it in a calcium-free solution, it's going to cease to stop beating. And why is that happening? Because whether it be the calcium-induced calcium release caused by this DHPR, which was allowing the amount of calcium coming in, or whether it be the extracellular calcium coming inside through the voltage-gated calcium channels, whatever be the case, we are very dependent on what? We are very dependent upon your outside calcium coming inside. Okay? So that it can stimulate the inside stores to go outside. So we are dependent on calcium. The calcium-free solution में the heart cannot beat. So that's one thing that I want you to know. We have already discussed about this circa and how is it modulated by phospholambin. Just remember, whenever there's an increased activity of cyclic AMP, it's going to activate your protein kinase A. That's going to inhibit your phospholambin by phosphorylating it. Okay? We've already talked about this. And don't forget, हमारा friend, that is your 3-sodium 2-potassium ATPase, sodium potassium ATPase. And what was it inhibited by? It was inhibited by digoxin. Okay? And where does digoxin bind? Very important MCQ. It binds to the obein binding site. Okay? It binds to the obein binding site. Okay? And digoxin, I think you might be knowing the mechanism as well. So let's discuss that because यहाँ पे हमारे पास opportunity है to do it. Whenever I inhibit this transporter, I'm going to have an increase in your intracellular sodium because the intracellular sodium को बाहर फेंक रहा था वो. तो right. So what will happen again? See this transporter. This is known as the NCX transporter. That is sodium calcium exchanger. What is it doing? It's throwing out the calcium to let the sodium come inside. And how इसका फायदा क्या होगा बेसिकली? जो भी हमारा एक्स्ट्रा सेलुलर कैल्शियम, जो भी हमारा साइटोप्लाज्मिक कैल्शियम जो डेवलप कर रहा है, जो बहुत ज्यादा बड़ा हुआ है, या तो हम उसे अंदर ले सकते हैं वाया दिस सर्का, और वी कैन थ्रो इट आउटसाइड द मायोकार्डियम का सार्कोलेमा वाया दिस एनसीएक्स. इफ आई इनहिबिट सोडियम पोटेशियम एटीपीएस, और अगर मेरा सोडियम इंक्रीज कर जाएगा, दिस सोडियम कैन नॉट फ्लो इनसाइड. व्हाई? बिकॉज यहाँ पे सोडियम ऑलरेडी इनसाइड है. इट्स गोइंग डाउन इट्स कंसंट्रेशन ग्रेडियंट. ठीक है, इट कांट गो डाउन इट्स कंसंट्रेशन ग्रेडियंट बिकॉज आपने कंसंट्रेशन ग्रेडियंट को अबॉलिश कर दिया बाय इंक्रीजिंग द सोडियम इंट्रासेलुलरली. So what will happen is calcium will also say I can't also move because calcium was also moving against what it was facilitating through this NCX that was going through outside. But iske karan we are going to have an increase in calcium developing inside, and that is the mechanism how that we are going to develop positive inotropy. ठीक है, via which drug known as digoxin used in heart failure. ठीक है, right? ठीक है. We have already discussed about this कि whenever we have any cardiac जो भी हमारी nerves है वगैरह, sympathetic nerve supply है, we know that they release norepinephrine predominantly because the nerve fibers do not have this enzyme known as PNMT. We have already discussed this. So whenever this acts on the beta 1 receptor, it's going to activate your this GS protein that's going to activate your adenyl cyclase, increase the cyclic AMP, phosphorylate of PKA, and that's going to lead to inactivation of your phospholambin that will further activate your circa. Just don't forget one more thing. That this beta gamma subunit जो रह गया है, that also activates your DHPR receptors directly. So we are seeing mechanisms how beta 1 receptors can act. ठीक है, so they are important. All right. ठीक है जी. So we have discussed about this already. We discussed about the ATP dependent calcium pump. We have discussed about the sodium calcium exchanger. It's a 3:1 exchange. Again, a frequent MCQ. And what is transporter known as? It's a secondary active transport because it's dependent upon your sodium potassium ATPase. जिसे आपने किससे inhibit कर दिया? Via digoxin. Right. So we have discussed all of this. We have discussed the electromechanical coupling, and again, it works on the same principle as the skeletal muscle contraction. So we are not going to go into that detail कि how is the power stroke generated, है ना? कि वो recoil कैसे होता है? How that amount of chemical energy is stored in the myosin heads and it undergoes a power stroke and then it recovers. So we can see all of that in nerve muscle physiology, which we have already discussed. ठीक है? Okay. So let's just see an action potential. So what is this action potential? So this action potential, what I'm going to talk about is something known as the fast action potential. Okay. So this is known as a fast action potential. And where do I see this fast action potential? I'll see it in atrial myocytes. Alright. I'll see it in ventricular myocytes. I'll see it in Purkinje fibers as well. Okay. So this is something known as a fast action potential. Why do I call it as fast? Can you see the upstroke? So this is the upstroke. So let's just discuss what are the phases. यहाँ पे हमारा RMP है. ठीक है. whenever there is RMP that's about minus 90 millivolts, I would say. So it's about at minus 90 millivolts. Okay. So whenever we are going to have some action potential whenever we're going to have some positivity coming into the cardiac myocyte, so uska potential is going to increase, and then what's going to happen? Voltage gated sodium channels are going to open. Okay. And we're going to have a very fast influx. Why? Because the sodium, we've already discussed the time and again, it basically follows a fast cycle. Matlab, it's going to open very fast. It opens very fast, opens fast, and it closes fast as well. Okay. So, जो rapid stroke है, that is known as your phase 0. This is phase 4, that is your resting membrane potential. Then we're going to have a phase 0. What is this phase 0? This is the हमारा phase known as your rapid depolarization, जहाँ पे हमारा minus 90 millivolts है, it's going to reach for about plus 20 millivolts. ठीक है? That is your generation of an action potential now. ठीक है? So now what is going to happen now? As I told you guys, कि sodium channels are fast to open, fast to close. So now they have closed. All right. And what are going to open? Potassium channels, on the other hand, are very slow to open. So they have started opening now. So I see this initial stage. This is known as the early rapid partial repolarization. Okay? So it's an early part of your repolarization, but it's partial. Okay? Early rapid partial repolarization, that's phase 1. And why is it happening? Because pehli, sodium channels have closed, potassium channels are opening, so we are seeing potassium efflux. तो उसके कारण RM जो हमारा potential है, that's going to drop, membrane potential. What about the next phase now? Next phase, we are going to have two things. The potassium efflux we're already seeing, but now the potassium efflux will be balanced by your L type of calcium channels opening. L type of calcium channels opening. And what is that going to lead to? That's going to lead to influx of calcium and efflux of potassium. And both of them are nearly the same. If both of them are nearly the same, we're going to have a stage known as your plateau. Okay? This plateau is usually at about 0 millivolts. Okay? Because हमारा क्या हुआ था initially, we had an initial partial repolarization वाली phase, उससे थोड़ा कम हो गया potential, but we are at 0 millivolts और यहाँ पे हमारी एक stage है known as your plateau. ठीक है? A very long stage, I would say. ठीक है? So very long stage, about 0.3 seconds in the ventricles. ठीक है? What next? The last phase is your phase 3. That is a phase 3 is repolarization. यहाँ पे हमारे calcium channels will close. The potassium channels are again opening and again, and that's going to lead to potassium efflux, and we're going to achieve your repolarization. So these are the 4 stages. So phase 4 is your complete repolarization, जहाँ पे हमारे membrane potential will reach to its resting membrane potential. ठीक है? And we've discussed about the different factors contributing to the resting membrane potential. We discussed about the Goldman-Hodgkin-Katz equation as well. We discussed about the role of sodium potassium ATPase as well. ठीक है? So four हमें याद रखनी है. That's your phase 4. Then your phase 1. Then the initial rapid repolarization. Then your plateau phase, that's phase 2. And then we're going to have the phase 3, that's the repolarization. Okay? If you see the action potential of a cardiac muscle, it's obviously uski jo duration that's going to be longer than what? Than your simple skeletal muscle. And that is one of the reasons why, because itni longer hai that they can't undergo tetanization. Okay? That's one of the reasons. Okay? Ki action potential itna lamba hai, absolute refractory period itna lamba hai, then we cannot achieve that amount of tetanization that we would have seen in a skeletal muscle. Okay? Alright. So this again we have seen, rapid repolarization is due to sodium channels opening, small repolarization is due to sodium channels becoming inactivated as well as some amount of potassium channel opening as well. Plateau we seeing due to potassium channel opening as well as your calcium L-type channels opening. Then repolarization we've already seen, and we have seen the resting potential as well. Okay. Right. Alright. So now we have discussed about all of this. We discussed about the ARP as well. What was this absolute refractory period? That was depolarization wali phase plus the initial, this is important, the initial 1/3 of your repolarization. Okay? So it's a very long absolute refractory period in case of your cardiac muscle. Okay? Right. All right. Okay. So now we're going to jump on to your second type of action potential, that's known as a slow action potential. Okay? Slow action potential. And sometimes this is also known as a diastolic action potential. Okay? This is also known as your diastolic action potential. And where is it happening? Mainly it's happening in the SA node and your AV node. Okay? And what exactly is happening? Let's try to see the difference between them. Why do you call it as slow? Because यहाँ पे हमारा जो main thing that is mediating your depolarization is not your sodium. इस case में it's mainly calcium. ठीक है? And इस case में slow action potentials जो हैं, they're generated frequently, and because these two cells are mainly, they have a property known as automaticity. मतलब they do not need external stimulus to fire their action potential. तो वो ऑटो एक्साइटेबल सेल्स हैं, दे कैन फायर देयर ओन एक्शन पोटेंशियल इन ड्यू कोर्स ऑफ टाइम. ठीक है, फॉर एग्जाम्पल वी नो कि जो हमारा एसए नोड इट फायर्स अबाउट 60 per minute or 70 per minute or 60 to 100 per minute, whatever be the case. ठीक है, एंड वी नो इन केस ऑफ योर एवी नोड इट्स मच लेसर. ठीक है, ऑलमोस्ट अबाउट 40 per minute. सो ये जो हमारी ऑटो एक्साइटेबिलिटी है, हाउ इज इट मीडिएटेड? सो लेट्स जस्ट सी दैट. ठीक है, ओके. सो यहाँ पे इफ यू सी द डिफरेंट फेजेस नाउ, यहाँ पे थोड़ी थोड़ी चेंज हुई है. फर्स्ट इज आई डोंट सी ए प्लेट्यू. तो फेज 2 के बारे में तो बात ही नहीं करेंगे, वी आर नॉट गोइंग टू सी, एंड नॉमेनक्लेचर रिमेन्स द सेम माइंड यू. ठीक है, तो व्हाट आर वी गोइंग टू सी? पहली बात, देयर आर सम चैनल्स व्हिच आर डिफरेंट ओवर हियर. ठीक है, देयर आर सम चैनल्स व्हिच आर डिफरेंट ओवर हियर. सो वी हैव समथिंग, वी हैव जो ये वाले स्टेज जो है, इफ यू सी गाइस, दिस स्टेज, दिस इज योर स्टेज 4. ठीक है, व्हाट इज द स्टेज 4 नोन एज? दिस इज नोन एज योर प्री पोटेंशियल. ओके, प्री पोटेंशियल मतलब this is that stage how is the cell going to generate its action potential. All right, how is the pre-potential mediated by? It's mainly by two channels. One is your funny channel. Okay, one is your funny channel, and funny channel के एक और नाम है, that's your HCN channel. Okay, it's known as your HCN channel. What do I mean by HCN channel is hyperpolarization. ठीक है, hyperpolarization cyclic nucleotide gated channel. Okay, cyclic nucleotide gated channel. And why do I call them as funny? All right, तो इनका funny का जो main इनका वो reason ये है that usually when I talk about sodium channels, they open during depolarization. But these HCN channels, if you see आराम से, and they're going to open during hyperpolarization. So that is how they're different from your normal sodium channels, and the scientists found it funny, and then इसका नाम is known as your funny channels. But now the other name is your hyperpolarization cyclic nucleotide gated channels. इसका मतलब ये है कि whenever your cyclic AMP is there, ठीक है, that's a cyclic nucleotide I would say, that's going to activate these channels. And what was activating your cyclic AMP? Can I say the beta 1 receptors present on the heart? So now I'm thinking one more thing, that beta 1 receptors are also going to increase the heart rate because they're going to increase this pre-potential. Where? In the SA node you would say. Okay, in the SA node. And that's one more thing. We have discussed about the beta 1 receptors, how they can contribute to positive inotropy. Here we are studying how the beta 1 receptors can contribute to positive chronotropy as well. So this is the phase 4. One part of the phase 4 is mediated by the HCN channels. Okay, and then the other part is mediated by special type of transient calcium channels. They're known as T type of calcium channels. Okay, so these are different. These are your T type, not L type. All right, L type are about to come. As soon as the potential reaches at about minus 40 millivolts, that is the firing level for another type of channels known as your L type of calcium channels. Okay, L type of calcium channels, latent, right? L stands for latent, T stands for transient. So this L type of calcium channels are the one which are going to contribute to your phase 0. That is your rapid depolarization. In case it's happening at a slower pace, we call it a slow depolarization. So phase 0 is due to the calcium mediated by L type of calcium channels. Phase 4 is mainly due to the funny channels, that's your HCN channels, as well as your T type of calcium influx. And what will happen again? I'm not seeing any plateau, fine. But I'm going to see a repolarization phase again that is mediated by a potassium efflux. And then what is happening here is, as we have discussed already, RMP in case of a SA node is very fluctuating. Okay? It ranges from about 45 se leke minus 60 millivolts. So what I'm seeing here is that it might reach even at a negative potential. That's at hyperpolarization. Okay? And that was when our जो हमारे friends and that's your HCN channels are going to bring it back to its resting membrane potential. And then उसके बाद what is going to carry its top? That's your T type of calcium channels. Till it reaches the threshold, that I'm setting at about minus 40 millivolts, and then it's going to fire its action potential. It's a slow type of action potential. I call it as a diastolic action potential. Okay? Where is it there? It's present in the SA node, it's present in the AV node. Okay? So we've already talked about it opens during hyperpolarization and it is gated by cyclic nucleotides. That's why it's known as the hyperpolarization cyclic nucleotide gated channel. Okay? Just remember the calcium current due to the opening of T channels completes the pre-potential as we have discussed. Okay? Alright. So now we move on to the conducting system of the heart. As we know, we have the SA node over here, we have the AV node over here. Sometimes people like to ask what is the location of your SA node, what is the location of your AV node. So let me just tell you about it. So what is the SA node? So the SA node is present in the right atrium, we know it, and where at the junction of the superior vena cava when it meets with the right atrium. Just at that junction, हमारा SA node present है. ठीक है? Make sense? What about the AV node? AV node, it basically lies at where? It basically lies at the interatrial septum, close to the tricuspid valve. So it's on the right side again. Okay? So it lies in the interatrial septum, close to the your tricuspid valve. Okay? So this is the SA node, this is the AV node. As we would see, SA node और AV node के बीच में जो हमें conduction mediate कराना है, that is mediated by something known as internodal pathways, and there are 3 which we will be discussing. ठीक है? As we have the AV node over here, ठीक है? And what we are going to have, we are going to have the AV bundle. The AV bundle is going to branch into bundle branches. That's your left bundle branch and your right bundle branch, and that's going to supply your myocardium from the subendocardial surface, as you can see, to your subpericardial or subepicardial surface. ठीक है? एंडोकार्डियम से एपिकार्डियम ते ऐसे इट्स गोइंग टू स्प्रेड. दैट इज द वेव ऑफ डिपोलराइजेशन इस फेज में स्प्रेड करेगी. ठीक है? सो वी हैव सीन दैट. ऑलराइट. सो वेयर इज द AV node? I told you it's at the right posterior portion of your interatrial septum close to the tricuspid valve. ठीक है? So that's important. So what were the 3 internodal tracks? So this is the SA node, this is the AV node. I'm saying there are 3 internodal tracks. We have to remember anterior, middle and posterior. And there are some names of it. Anterior one, internodal, is known as your Bachmann's bundle. The middle one is known as Wenckebach's bundle, and your posterior one is known as your Thorel's bundle. Okay? And if you remember, this is the right atrium. How are we going to supply the left atrium if there is an interatrial septum? Because we have a branch of the anterior bundle which is going to supply the left atrium for us. It's a branch of the anterior bundle, that's the Bachmann's bundle, which is going to innervate the left atrium. Okay? So 3 branches: Bachmann's bundle, Wenckebach, and your Thorel. Okay? So now let's see the sequence of excitation. If you see the SA node now, SA node से लेके AV node तक, how much time is going to take? It's going to take about 0.03 seconds. ठीक है? It's very important. ठीक है? तो हमें याद रखना है, via these internodal pathways, SA node से लेके AV node तक, how much time did it take? It take about 0.3 seconds. 0.03 seconds. I'm sorry. 0.03 seconds. Sorry. ठीक है? Now what's going to happen? As soon as the impulse is going to reach the AV node is known as that portion of your the conducting system, जहाँ पे the conducting system is very slow and the conductive system is very small in amplitude because it has less amount of gap junctions as compared to your SA node. तो यहाँ पे AV bundle is going to delay it. As you can see, the conduction velocity of the AV bundle is the slowest. That is 0.01 meters per second. So यहाँ पे what's going to happen is there's going to be a delay of your 0.09 seconds. Can you see it? So the delay is about 0.09 seconds. What next? From the AV node to the AV bundle, it takes about another 0.04 seconds. ठीक है? So what did the पूरा amount कितना हो गया? That is 0.09 seconds plus 0.04 seconds. So it makes about 0.13 seconds. And if I count it from the point SA node से लेके now where AV bundle तक, then I can say it is at 0.16 seconds. ठीक है? So total time अभी तक elapsed हुआ 0.16 seconds. What next? AV bundle से लेके right and left bundle branches and your Purkinje fibers, because Purkinje fibers travel at about 4 meters per second. That is the fastest. What was the slowest? AV node, right? So अगर ये 4 meters per second fast करते हैं, तो all of that impulse is going to spread across the ventricle in how much amount of time? It's going to reach the Purkinje fibers in about 0.03 seconds again. ठीक है? So let's just see how is it happening. If we can make it over here, ठीक है? तो SA node, if we take it as 0, internodal pathways के through now we have reached the AV node, and AV node कितने time पे? We have reached it about 0.03 seconds. Why the relatively fast internodal pathways? ठीक है? अब AV node में एक डिले हुआ कितना? 0.09 seconds का. उसके बाद क्या हुआ? AV bundle से लेके AV node से लेके AV bundle तक कितना टाइम लगा? 0.04 seconds. ठीक है? टोटल में अगर मिला दूं इन सबको, it makes about 0.16 seconds. ठीक है? And the last portion I'm saying कि AV bundle से लेके Purkinje fibers and travel करने में पूरा ऐसे टाइम लग गया, again something 0.3 seconds. I'm so sorry, तो कुछ difficulty हो गई थी in the stream, so we are back again and we've discussed all of this conductive system, so you can revise on your own. ठीक है? All right. So just seeing the functions, okay, why is the AV node such a slower pathway and why is it behaving like a tortoise? So let's just see. It has a less number of gap junctions, so that's one thing. Okay? It has a slow type of action potential that exacerbates the thing, and the last portion is it has a small fiber diameter. Okay? One more reason I can say to you guys is कि mainly in जो cells में है ना, in cells they're going to have what? The longitudinal axis of the cells जो है, it's going to be perpendicular to the current flow. ठीक है? That's the one more reason behind it. So there are decreased number of gap junctions. The longitudinal axis of the cells is perpendicular to cross, so more membranes are going to be crossed. And third is कि इसका RMP कम है, so obviously reduce electrical gradient for calcium, so slow depolarization is there. So these are the 3 reasons why conduction velocity of the AV node is least. And the maximum gap junctions are present in the Purkinje system. That is why इसकी conduction velocity was at about 4 meters per second. ठीक. So we've discussed all of this. Okay, we've discussed about the internodal pathways as well. SA node से लेके AV node तक 0.03 seconds. AV node has a 0.09 seconds का intrinsic delay. AV node से लेके AV bundle तक 0.04 seconds. And bundle branches से लेके Purkinje fibers, it's going to take about 0.03 seconds. And then to the whole of the heart, it's going to take about 0.01 seconds again. Okay, so all of this is done. So if I say SA node से लेके पूरा ventricle septal तक, it's going to take about 0.06 seconds. And then later 0.03 seconds again from the bundle branches to travel to the Purkinje fibers. ठीक है. So we have discussed, ये हमारी intrinsic frequency है. SA node की it's about 70 to 80 and maximum it's about 100. More than 100 we call it as tachycardia. ठीक है. AV node it's about 40 to 60. And if we talk about the his bundle mainly it's 15 to 40 and Purkinje fibers are also 15 to 40 only. ठीक है. So ये हमारे mainly discharge rate per minute हो गया. Purkinje fibers के लिए 15 to 40 है. His bundle and AV node it's same 40 to 60 and your sinus node के लिए it's about 70 to से लेके 80. Just remember something known as overdrive suppression. What do I mean by that? What I mean is, whenever the SA node is firing at such, इतने ज़्यादा discharge rate पे अगर हमारा SA node fire करे, what's going to happen? Since the rhythmicity of the SA node, that's a 60 to 100 impulses per minute, is greater than that of the other latent pacemaking sites in the heart, that is your AV node or your His bundle or your Purkinje fibers. Firing of the SA node tends to suppress the automaticity in the other loci. So this is known as overdrive suppression. Okay? Very important. Right. So now we're going to talk about the cardiac cycle now. We know cardiac cycle की अगर हम average duration देखें तो we call it as कि अगर हम heart rate 75 लेते हैं per minute and 1 minute में it's about 60 seconds तो एक basically cardiac cycle के duration it amounts to about 0.8 seconds जो इससे हम standard लेते हैं. ठीक है. So that is when the heart rate 75. Adjust accordingly. So 0.8 seconds में से we have two cycles. Atrial cycle that is going on its own, ventricular cycle that's going on its own. Both are made up of 0.8 seconds. But there is a difference. Atrial cycle में the systole is only 0.1 second. That is the shortest. ठीक है? And the diastole is the longest. That's 0.7 seconds. In case of the ventricular cycle, the systole is about 0.3 seconds and your diastole is about 0.5 seconds. ठीक है? So that's your cardiac cycle. So now we're going to discuss the different portions of the cardiac cycle और उसके different वो क्या हैं. So when we talk about your systole, it's mainly about 0.3 seconds. Now we have to adjust the 0.3 seconds. So the first phase is known as your isometric contraction. That's your 0.05 seconds. We call it as isovolumetric ventricular contraction. The second phase is your rapid ejection phase. Okay? It's going to be rapid, but it's going to last for a shorter amount of time. It's about 0.17 seconds. Okay? And what about your slow ejection phase? That's going to be another 0.15 seconds. So we add it all up, it's going to make about 0.3 seconds. So isovolumetric ventricular contraction followed by a rapid ejection phase of 0.1 seconds and a slow ejection phase of 0.15 seconds. Okay? What about the diastole? We have something known as the protodiastole. Protodiastole वो portion है जहाँ पे हमारा अभी भी जो AV valves हैं, they have not closed now. ठीक है? So this is that portion जहाँ तक हमारे AV valves close नहीं होते. So after the protodiastole, which is a very short amount of time, I would say it's about 0.04 seconds, we're going to have AV valve closure as well, और semilunar valves हमारे close भी होंगे in case of ventricular diastole. ठीक है? So now the ventricles is going to relax, and that stage is known as isovolumetric ventricular relaxation. Why is it isovolumetric? Because nothing is coming inside the ventricles, nothing is leaving the ventricles. AV valves भी closed हैं, and हमारे semilunar valves भी closed, and that is why I call it as isovolumetric relaxation. Now what's going to have? It's going to undergo rapid filling phase. That's your 0.1 seconds, 0.17 seconds. Then your diastasis, that's your slow filling phase. That's your 0.2 seconds. So sorry for the interruptions. So as we were discussing, कि ventricular diastole में we have the protodiastole that is 0.04 seconds. We have the isovolumetric relaxation that's about 0.06 seconds. Then we have the rapid filling phase of 0.1 seconds. Then we have the slow filling phase of 0.2 seconds. And the last में we have the last filling phase or your active filling phase of 0.1 seconds. ठीक है? This is sometimes also known as the atrial kick as well. Okay. तो cardiac cycle हमारी ये है and let's just discuss them in detail now. ठीक है? So we're going to start at the level of the contraction. ठीक है? So let's see here. As soon as the ventricles are going to contract, okay? So I'm saying the ventricles are contracting. All right. So ventricles are basically contracting. What's going to happen is the ventricular pressure is going to increase. As soon as the ventricular pressure is going to increase, one valve is going to close for sure. What is that valve? Let's see. So what is happening? This is closed already. अभी एक हमने छेड़ा नहीं है. But one valve which was earlier open was your AV valves. Okay? So now as soon as the ventricular pressure is going to increase, it's going to exceed the left atrial pressure. Okay? And what's going to happen? This valve is going to close. So we are going to have a closure of your AV valves. ठीक है? Just before that is इसके बाद हमारी isovolumetric ventricular contraction occur करेगी. ठीक है? Very important. This closure of your AV valves, what can I call it as? I can call it as S1. So we are going to correlate your all of this cardiac cycle with your S1, S2, S3, S4 as well. ये हमारे standard questions होते हैं and we are going to discuss your Wiggers diagram as well. ठीक है. So now अभी basically what is happening is we have something known as isovolumetric ventricular contraction. This is isovolumetric but the pressure is keeps on increasing. So the ventricle is sealed over here. यहाँ से भी it is sealed and now the pressure is increasing. Till when? Till the ventricular का pressure it becomes more than the diastolic blood pressure of the aorta. ठीक है. तब क्या होगा हमारे सेमिलुनर वाल्व्स विल ओपन. दैट इज इन केस आई एम डिस्कसिंग योर एओर्टिक वाल्व. ठीक है. डू द वाल्व्स मेक एनी साउंड ऑन ओपनिंग? नॉर्मली दे डोंट. तो अभी भी वी आर आल्सो डिस्कसिंग कि नॉर्मली दे डोंट. इफ दे मेक देन वी कॉल इट एज अ क्लिक. तो अभी वो डिस्कस नहीं कर रहे हैं हम. तो मेनली व्हाट इज हैपनिंग आइसोवोल्यूमेट्रिक वेंट्रिकुलर कंट्रैक्शन लास्टिंग फॉर अबाउट 0.05 सेकंड्स के बाद what has happened is the semilunar valves have opened. Do they make a sound? They don't make a sound. What's going to happen? We're going to have rapid ejection phase lasting for about 0.1 seconds. जहाँ पे हमारा 2/3 of the blood has been emptied, which were present in the ventricular cavity. Then we're going to have the slow ejection phase. ठीक है? Sorry, I'm sorry. It is rapid, but it is only contributing about 1/3 of the ventricular blood, and this is contributing to about the 2/3. ठीक है? So rapid ejection phase of 0.1 seconds, slow ejection phase of 0.15 seconds. And now what's going to happen is later on, the ventricles are going to start relaxing now. Okay? So now what is happening is as soon as the ventricle have undergone their contraction and the action potential is over, now the ventricles start relaxing. Till they reach a point, now the ventricles are relaxing. What do I call this phase as? Protodiastole. Has the semilunar valves closed right now? Abhi nahi. Okay? So let's just see. As soon as the semilunar valves close, I will call कि protodiastole खत्म हो चुका है, and now I am on to a different phase. So before, from the point when the ventricles start relaxing till the closure of the semilunar valves, I'm going to call this phase as protodiastole, lasting for about 0.04 seconds. Okay? And now what is the scenario again? Now the scenario is, now I'm going to have isovolumetric ventricular relaxation. क्यों? Because first thing, हमारे semilunar valves have closed, and अभी I'm yet to open these valves which have already closed here. जो मेरे closure of the हमारे क्या थे? Closure of the AV valves. अभी I have not opened them. ठीक है? When will I be able to open them? When this ventricular pressure decreases so much, then again the left atrial pressure is going to exceed the ventricular pressure. Then only these valves will open. ठीक है? So now isovolumetric ventricular relaxation का point ही ये है that the ventricles are going to relax at such a level कि the left atrial pressure जो है that's going to increase now, and I'm going to see an opening of an AV valve. Do they make a sound on opening? Again not. If they're making a sound on opening, that is the AV valves, then I'm going to call it as a snap. But that's a different additional sound. अभी we are not going to discuss that. तो IVVR done हो गया. Now अब क्या होगा? अब ये अगर open हो जाएगा, now the ventricle is going to get filled. तो दो phases, rapid filling phase, lasting for about 0.1 seconds. Then I'm going to have a diastasis, that's a slow filling phase, lasting for about 0.2 seconds. And last में, what is happening is, do you remember guys? Okay, so this phase was actually coinciding with your ventricular diastole. I call it as the atrial systole, and this is going to provide its last filling phase, that is your active filling phase. जिससे हमारा 100 से now it's going to contribute another 20 ml by atrial contraction. Now it's going to become 120 ml. ठीक है? So what do I call this as? End diastolic volume. Because अभी मेरा पूरा diastole खत्म हो चुका है. Whatever blood I have in the ventricles after that diastole I call it as the end diastolic volume, which amounts to about 120 ml. और जब मैं उसे eject कर दूंगा, then I'm going to have something remaining as end systolic volume. And what is the ejected part known as? That's known as the stroke volume. ठीक है? So let's just see here. This is very very important. So when we are discussing about the atrial systole, whenever the atria is undergoing systole, ECG पे we are going to see a P wave. That makes sense. ठीक है? What about the JVP? Because atria are going to contract now, what's going to happen? We are going to see an A wave. Because whenever the atria are contracting, if this is my right atrium for instance, and I'm calculating the JVP, so the atria are contracting. Whenever they're contracting, obviously the pressure inside the atria will increase. So that will transmit as to the internal jugular vein as what? That will be a A wave in case of your JVP. Okay? Do I see a heart sound here? Definitely I do. In some individuals, I can see an S4. Okay? So this is known as your S4, also known as your atrial kick. Okay? So this is your S4. All right. What about the then atrial systole के बाद? That is the last phase of ventricular diastole. I'm going to begin your contraction. That's a systole, ventricular systole. The first phase is the isovolumetric ventricular contraction. Okay? What will it amount to be as? QRS complex. Okay? QRS complex. Now what is going to start with? Obviously it's going to start with your AV valve closure. And what do I see? I see an S1. Okay? S1 यहाँ पे मिलेगा हमें. So what is the heart sound associated with? That's your S1. Okay? and when it's going to contract, the जो हमारा ट्राइकस्पिड वाल्व है दैट्स गोइंग टू अपटर्न इनटू द राइट एट्रियम, और राइट एट्रियम का क्या होएगा, बेसिकली वॉल्यूम कम होएगा तो प्रेशर इज गोइंग टू इंक्रीज नाउ. ठीक है, इट्स बेसिकली लाइक अ रिकॉइल. तो इस केस में आई एम गोइंग टू सी अ सी वेव, दैट्स अगेन अ पॉजिटिव वेव इन केस ऑफ ए जेवीपी. ऑलराइट, देन अब इसके बाद हमारा होएगा रैपिड इजेक्शन फेज. व्हाट्स इट कॉरेस्पॉन्डिंग टू एन ईसीजी, दैट्स कॉरेस्पॉन्डिंग टू योर एसटी सेगमेंट. अब इसमें हमारे रैपिड इजेक्शन फेज में क्या होगा, नाउ द वेंट्रिकल इज नॉट अ क्लोज कैविटी, नाउ द सेमिलुनर वाल्व्स आर ओपन. व्हाई? बिकॉज वेंट्रिकुलर प्रेशर इतना एक्सीड हो गया कि हमारा डायस्टोलिक ब्लड प्रेशर ऑफ द एओर्टा से वो ज्यादा है. सो नाउ आई एम गोइंग टू सी द सेमिलुनर वाल्व्स आर गोइंग टू ओपन. ठीक है, व्हाट अबाउट द स्लो इजेक्शन फेज, इट्स एट द लेवल ऑफ द टी वेव नाउ. ठीक है, नाउ दे आर स्टार्टिंग टू रिलैक्स. हैव दे रिलैक्स कंप्लीटली? नो. एंड द लास्ट फेज इज योर प्रोटोडायस्टोल एंड एज वेल एज योर आइसोमेट्रिक रिलैक्सेशन. एंड प्रोटोडायस्टोल के एंड में हमें क्या मिलेगा, वी आर गोइंग टू सी द क्लोजर ऑफ द सेमिलुनर वाल्व्स. So which heart sound I am going to see? I am going to see an S2. ठीक है, and just remember, rapid filling phase of the ventricle में we are going to see S3. ठीक है, AV valve will open and we are going to see S3. And the last one, slow filling phase में we don't have any characteristic thing. All right, so this is important again. So this is what I was telling you about. ये पूरे diagram को we call it as the Vigor's diagram. जहाँ पे हम बहुत सारी चीजों को compare कर रहे हैं. We are comparing the aorta का pressure. So this is the aortic waveform I would say. We are comparing this thing. This is your ventricle का pressure. We are comparing the ventricular pressure. ठीक है. We are comparing the atrial pressure. We are comparing the ventricular volume as well. ठीक है. And we are comparing the electrocardiogram and phonocardiogram. ठीक है. So इस पूरे portion को we call it as the Vigor's diagram. As you can see, different portions में, as we have already seen, before your beginning of your ventricular systole, ठीक है, that is before your IVVC stage. What heart sound are we going to see? We are going to see S1. हमने already पढ़ लिया. When is the S2 is going to occurring? ठीक है, S2 हमारा कब अकर होएगा, when after the end of your protodiastole, or I can say before the start of your IVVR. ठीक है, same goes for your S3. When was S3 occurring? Rapid filling phase. And what about S4? If it is there, then it's going to correspond to your atrial systole. That's your atrial kick. That is the active filling phase of the ventricle. So this is very super duper important कि we remember कौन कौन सी stages में हमारे क्या क्या relevant portions हो रहे हैं. We've already discussed this, how the first heart sound generated mainly due to the closure of the AV valves. When is the second heart sound generated? Due to the closure of the seminal valves. तो आज हम basically ये दो ही discuss करते हैं. Just remember, how do I remember it as? I think I learned it from Dr. Najib was कि it's like a girl is saying to a man, will you marry me? And the man says yes. ठीक है? So girl की frequency कैसी होती है? ठीक है? So इसके accordingly we can see. Alright, तो first heart sound and second heart sound को how we can compare is कि जो हमारा S1 है, that is your boy. That is going to say, will you marry me? और boys की frequency क्या होती है? That's going to be on the lesser aspect. And duration क्या है? Will you marry me is a 4-worded sentence. And what about yes? Yes is a 1-worded sentence. तो S1 की बात ये है, S1 is going to be at a lower frequency but for a longer amount of time. And your S2 is going to be at a higher frequency for a shorter amount of time. And that's how I remember it. ठीक है? S3 we've already seen, that's a rapid ventricular phase. And fourth heart sound we've already seen, that's going to correspond to atrial systole, or I can say the A wave as well. Sometimes ये भी क्वेश्चन पूछ सकते हैं. Which heart sound is going to correspond to your A wave in JVP? Then we can say the fourth heart sound. ठीक है? So that's the questions can be framed as well. Now we've already discussed this कि stroke volume क्या है हमारी? That is the amount of blood which is ejected by the ventricle during the rapid ejection phase, slow ejection phase. ये हमारे हम क्या कहते हैं उसे stroke volume. That amounts to be about 70 to 90 ml. Okay. Then what do we have the end diastolic volume? कि after the end of your diastole, how much amount of blood is remaining in the ventricles? That corresponds to about 120 से लेके 130 ml. ठीक है? And end systolic volume क्या हो गया? End diastolic volume minus your stroke volume. कितना आपने eject किया वरना from what you had. So that is known as your end systolic volume. That corresponds to about 50 ml. What about the ejection fraction? That says stroke volume divided by your end diastolic volume into 100. So this ejection fraction comes out to be 55 से लेके 68%. ठीक है? So this is very important when we are going to discuss heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. ठीक है? Cardiac output कितना है? Stroke volume into your heart rate. ठीक है? Stroke volume into heart rate. So that's going to be about 5 liters per minute. What about the cardiac index? So that is cardiac output divided by the body surface area. ठीक है? इसकी रेंज बहुत वेरिड है, 2.8 से लेके 4.2, बट आई रिमेंबर इट एज 3.2 liters per minute per meter square. That's for your body surface area. ठीक. Alright, so this is a pressure volume curve in case of a ventricle now. So let's just try to make sense of it, what is actually happening. So we can start from here, alright. So यहाँ पर हमारे 50 ml है. What is this? End systolic volume. This is the amount of blood which is remaining inside the ventricle. अभी ventricle fill नहीं हुआ है. So we're going to do filling now. So now this is the period of filling. So this is what 50 से लेके now we're having 120 ml it's going to become. ठीक है? And after the filling has commenced, मतलब filling खत्म हो गया है, what's going to happen? The mitral valve is going to close. Why? Because the ventricle has started to contract. तो mitral valve closure यहाँ पे हमारा S1 मिलेगा. तो sometimes ये भी एक इमेज आ सकती है pressure volume curve of the ventricle की, and we can be expected to ask what is this phase या what heart sound is being there. ठीक है, तो we can have questions like that as well. तो stroke volume से लेके end-diastolic volume तक हम पहुंच गए 120 ml तक, and now the mitral valve will close just before the isovolumetric ventricular contraction. ठीक है, we've already discussed this. अब इसमें क्या हो रहा है? Volume if you see is remaining the same. ठीक है, 120 ml था, 120 ml ही है, isovolumetric है. तो इट्स नाउ गोइंग टू रीच अ स्टेज जहां पे हमारा वेंट्रिकुलर प्रेशर इज गोइंग टू ओवरशूट द डायस्टोलिक ब्लड प्रेशर ऑफ योर एओर्टा, एंड नाउ द एओर्टिक वाल्व इज गोइंग टू ओपन. विल इट मेक अ साउंड? नो, वी डोंट नीड टू कंसर्न आवरसेल्व्स. अब हमारा पीरियड ऑफ इजेक्शन होगा. वी नो द रैपिड इजेक्शन फेज, वी नो द स्लो इजेक्शन फेज, है ना. उसके बाद हमारा बेसिकली क्या होगा? वी आर गोइंग टू हैव द एओर्टिक वाल्व क्लोजर. ठीक है, बट बिफोर द वेंट्रिकल स्टार्ट टू रिलैक्स and your aortic valve closure, we see a very short stage known as your protodiastole. ठीक है, हमने ऑलरेडी पढ़ा है. That corresponds to 0.04 seconds. And as soon as the aortic valve close, we're going to see S2. और अब क्या होगा बेसिकली हमारा? Now I'm going to see S2 has closed. ठीक है, अब the ventricles have again become a closed cavity, and now I'm going to drop the ventricular pressure till I reach lesser than the left atrial pressure. And what's going to happen again? Mitral valve will open. ठीक है, so this is where the aortic valve close, and this is the IVVR. It's going to relax. Now it's going to open again and going to permit filling of the ventricles again. So this is the pressure volume loop. ठीक है, and what is this stage? This is your stroke volume. That's the difference between your end-diastolic volume and your stroke volume and your end-systolic volume. ठीक है, I hope it makes sense. I think you can solve it on your own as well. So the incorrect pair is, ठीक है, so let's just try to solve it. So they're saying that point A पे the first heart sound at point C. You can solve it on your own. I'm going to display it. ठीक है, and just make yourself comfortable and just try to solve this MCQ. All right, ठीक है. So you can solve these as well. So you can try to see what's going to happen again. All right. Take it. So now we're going to discuss something about the pulse. Okay. Pulse waveform. So what is the definition? It's a waveform felt by the finger produced by cardiac systole over the vessel. So it's a waveform which is felt by the vessel. Okay. Let me just tell you one more thing very clearly. Abhi outset pe hi. Pulse is a waveform. Okay. It's not the actual blood. So यहाँ पे थोड़ी सी प्रॉब्लम ये होती है that we forget the blood velocity is different from the pulse velocity. Pulse velocity travels at about 5 meters per second. That's a lot. ठीक है, whereas the blood velocity, can you imagine, it's only 0.2 meters per second. मतलब it travels 20 centimeters every second, whereas it is traveling about 5 meters. ठीक है, so just remember blood velocity and pulse velocity are different things. Waveform आगे तक पहुंच सकती है, pressure आगे तक generate हो सकता है. Try to think it as कि मान लो you have a vessel and whenever you want more blood in that vessel you have to dilate it, ना, you have to increase its caliber. So this is the pulse and we are palpating it as the pulse. So this will obviously happen आगे की तरफ, then the blood will enter and accommodate itself into it. ठीक है, so what is the pulse? इसका travels at about 5 meters per second. When you have to see the rate and rhythm of the pulse, we basically go for the radial, and we have to see the volume and the character of the pulse, we basically go for the carotid. And I think carotid हमें पता है, that's medial to the sternocleidomastoid at the level of the thyroid cartilage. We can palpate it against the Chassenach's tubercle. ठीक है, and just see कि हमारा we're having different arteries and we are going to see after the cardiac systole how much time is it going to take for the pulse waveform to reach it. ठीक है, so let's see. For its shortest for carotid. Carotid मतलब cardiac systole के बाद 30 milliseconds after the cardiac systole we're going to see the pulse waveform in the carotid. For the brachial it's 60 milliseconds. For the femoral now it's 75 and for the radial is 80. ठीक है, तो 80 मतलब femoral में पहले पहुंचती है as compared to the radial. So that's my whole point. ठीक है, all right. Just remember both the carotid should not be palpated simultaneously as we know. ठीक है, because that can lead to vasovagal syncope due to stimulation of your baroreceptors. ठीक है, वहाँ पे जो हमारे carotid baroreceptors हैं, they can get stimulated. We can have vasovagal syncope as well. ठीक है, right. So as you can see, aorta में it's 4 meters per second, but as we see go on to the smaller arteries, the pulse की velocity is also increasing. So it's becoming about 16 meters per second. And with advancing age, the pulse velocity moves faster. Very important thing. ठीक है, यही important है. मतलब basically everything that elderly do is basically slow, but the pulse in them is going to travel at a much higher speed due to the arteriosclerosis of the walls. ठीक है, just remember that. So rate we already know, we can have 60 to 100 per minute. We can have less than 60 is known as brady and more than 100 is known as tachycardia. We can see some bradycardia examples. We can have physiological like sleep in athletes, and pathological में mainly it's hypoxia. It's central mechanisms. Hypoxia के case में hypothermia, we can have sick sinus syndrome, right? That's also known as the sinus tachybrady syndrome. इसमें we can have different things. We can have bradycardia. Sometimes it might be associated with some amount of A blocks as well. ठीक है, we can have hypothyroidism. Inferior wall MI, very important, because inferior MI basically, why does it occur? Because the inferior portion of your myocardium is supplied by the right coronary artery. and the right coronary artery, उसकी जो first branch है, that's your SA nodal artery and then your AV nodal branch. ठीक है? So if the SA node and your AV node is going to be affected, we're going to see bradycardia obviously. So inferior wall MI, when you're going to discuss ECG की sections, one of the indicators is bradycardia. ठीक है? And we can see an increase in ICT. Okay? This increase in ICT is known as the Cushing's reflex. So let me just tell you, whenever we're going to see an increase in the intracranial pressure, we're going to see some mechanisms by which we are going to modulate the cerebral perfusion pressure. As we all know, cerebral perfusion pressure is your that is the mean arterial pressure minus your ICP. Okay? So if the ICP is increasing, to maintain the amount of cerebral perfusion pressure, that's known as cerebral autoregulation, I need to increase this mean arterial pressure. Do I not? अगर हमारा MAP इंक्रीज होगा तभी तो हमारा cerebral perfusion pressure मेंटेन रहेगा. That is the reason why, due to some mechanisms, Cushing reflex के through, what are we going to do? We're going to see an increase in blood pressure. But whenever that blood pressure is going to increase, what are we going to have? We're going to have bradycardia due to what? Due to your baroreceptors का trigger. That is why we're studying bradycardia, Cushing's reflex due to increase in intracranial tension. Beta blockers can lead to bradycardia, we know. CCBs can lead to bradycardia, we know. We know हमने already पढ़ा था, that is a slow action potential is mainly mediated by our calcium. So calcium channel blockers can affect that. Obstructive jaundice is a very important cause, and a vasovagal syncope. Tachycardia we can have physiological like infants, children's, exertion and emotion. Whereas pathological we can have different types of fibrillation or your tachycardia. We've seen that. Anemia, beriberi, thyrotoxicosis are very important. Fever, very important thing. Okay? And we have something known as sphygmothermic dissociation that is seen as Fagit sign in case of typhoid or your different conditions as well. Okay? I think Q fever as well. So that is your Fagit sign. But we can have fever में mainly हमारा heart rate increase करता है. AV fistula, pheochromocytoma, your congestive heart failure, decrease in blood pressure can lead to increase in heart rate due to your baroreceptors as well. Shock हो गया, atropine, beta agonist, thyroxine and nicotine. All of these are causing tachycardia, right? Take it. So as we've seen, Fagit sign, that is your sphygmothermic dissociation. That's your typhoid, Legionella, Q fever, scrub typhus. Rarely, dengue and malaria can also cause it. Okay? Then the second thing we are going to see is the rhythm. That we see कि rhythm और rate हमें basically हमें radial से देखना है. तो we can see rapid regular rhythm in case of your SVT, VT. Irregular rhythm, that's your atrial fibrillation and atrial tachycardia. ठीक है? It could be atrial tachycardia or flutter with varying blocks. Very important. ठीक है? तो either it is atrial fibrillation or AT with varying blocks. And last में हमारा regularly irregular rhythm that's seen mainly in ventricular premature contraction. It could be seen in ventricular bigeminy, trigeminy. ठीक है? So these are the examples. And when I talk about the volume, तो what are we seeing? Volume कैसे ऑब्जर्व करेंगे? जो हमारी मिडिल फिंगर है, that's the palpating finger. पर इस केस में वॉल्यूम बिकॉज वी आर असेसिंग एट द कैरोटिड, तो वी कांट से बिकॉज कैरोटिड में मेनली वी यूज द थंब. ठीक है, पर वरना वैसे इफ यू आर पैल्पेटिंग एट अदर पेरिफेरल आर्टरी, देन वी कैन सी द ऑब्जर्विंग द लिफ्टिंग ऑफ द मिडिल फिंगर, और वी कैन सी द ऑब्जर्विंग द लिफ्टिंग ऑफ द थंब. तो जितना लिफ्ट हो रहा है दैट मीन्स योर वॉल्यूम उतना ज्यादा है. ठीक है, तो पल्स प्रेशर के अकॉर्डिंगली हम कैलकुलेट करते हैं. द पल्स प्रेशर इज लेस देन 30, आई एम गोइंग टू कॉल इट एज अ स्मॉल वॉल्यूम पल्स. व्हेन इट्स गोइंग टू बी मोर देन 60, आई एम गोइंग टू कॉल इट एज अ लार्ज वॉल्यूम पल्स. Now I have some characters. Characters again we say कि characters हम basically we're going to see at the carotids again. So we can have something known as the hypokinetic pulse. ठीक है? So hypokinetic pulse can we see, and we can have something known as the anacrotic pulse. So this anacrotic pulse is known as pulsus tardus. मतलब इसमें क्या हो रहा है? हमारी pulse is going to be having a delayed phase. It's going to have a delayed increase. ठीक है? So that's known as your anacrotic pulse. मतलब हमारा slow up stroke है, and peak is also delayed. Where is it seen at? Mainly it is seen in AS. That's your aortic stenosis. ठीक है? Then we can have something known as pulsus parvus at tardus. This was only pulsus tardus. Tardus मतलब at occurring slow, right? Tardus means slow. What about parvus? Parvus anywhere means small. ठीक है? When we say 7p chromosome, तो P stands for parvus. तो मतलब वो small, short arm पे है. तो same pulsus parvus at tardus मतलब यहाँ पे peak तो delayed है ही, upstroke भी कम है, but यहाँ पे क्या है? हमारा वॉल्यूम भी कम हो रहा है. That is why it's known as pulsus parvus at tardus. That is seen in severe AS. ठीक है? Very severe or severe aortic stenosis में we're going to see it. Okay. Next we're going to have an hyperkinetic pulse, जहाँ पे हमारी large volume pulse है, जिसका wide pulse pressure है, और हमारी जो बहुत सारे इसमें conditions हैं, we can have anemia, पेरिपेरी anemia हो गया, pyrexia हो गया, beriberi हो गया, AV fistula, Paget's disease. ठीक है? Paget's disease mainly is due to the mainly कि वहाँ पे जो भी हमारा Paget's disease है, वहाँ पे we're having osteoplastic हमारे mixed reactions हो रहे हैं, इसके कारण blood flow is increased over that portion of that bone. ठीक है? We can have something known as the collapsing pulse, that is the water hammer pulse or the Corrigan's pulse, that is mainly seen in your AR. Okay? I'm going to go a little bit faster now. We can have pulses bispherians. What do I mean by bispherians is कि systole में I'm going to see 2 peaks. Okay? That is your bispherians. Okay? When I talk about a dicrotic pulse, that means एक systole में और एक diastole में. ठीक है? When I am talking about bispherians, that is mainly 2 peaks हमें systole में ही मिल रही हैं. ठीक है? So what is that due to? mainly it can be seen in severe AR. And why? Let me just tell you about it. Whenever I talk about a pulse, I'm going to see some waves. So first wave that I palpate is known as the percussion wave. Okay? What is this percussion wave? जितना हमारा left ventricle eject करेगा blood into the artery, that is your उसके कारण जो भी हमें waveform feel होगी, that's a percussion wave. What about the tidal wave? Tidal wave हमारी वो waveform है जब aorta recoil करेगा due to the wind castle effect. I'm going to see a tidal wave. What about the dicrotic notch? That might be seen due to a closure of the aortic valve. And then I'm going to see a dicrotic wave. And why is that happening? Mainly it's a reflective wave from the periphery. मतलब मान लो ये मैं palpate कर रहा हूँ artery और ये मेरी peripheries हैं. What's happening is all of that blood is going here and that will return eventually. Why? Because यहाँ पे peripheral resistance बहुत ज़्यादा है और ये जो reflected wave होएगा that's going to appear as a dicrotic wave. ठीक है? So अभी when I'm talking about Bispherians pulses, that I mean कि यहाँ पे हमारे दो सिनेरियोज हो सकते हैं. हमें percussion wave मिल रहा है and due to some reason we are seeing a prominent recoil or we are seeing a prominent T wave. And one example would be a severe aortic regurgitation जिसमें हमारा aortic recoil is increased. तो उस केस में P wave is going to be very strong because stroke volume ज़्यादा है. क्यों? Because end diastolic volume ज़्यादा होएगा. Because we are having severe aortic incompetence. सारा का सारा aorta का जो blood आप eject कर रहे हो, that is flowing back into the ventricle. The ventricle is overfilling, and now when it's going to contract due to Frank-Starling mechanism, it's going to generate more amount of stroke volume, more amount of pressure, and hence उसके कारण percussion wave भी ज़्यादा है and recoil भी ज़्यादा होगा. तो obviously we are going to see Bispherians pulse in case of a severe AR. What about your AR with mild MS, mild AS? ठीक है? उस केस में क्या हो रहा है? We are going to see a prominent wave. We're not going to see a prominent T wave, but उनके बीच में I'm going to see a dip. ठीक है? So that is mainly your AR plus mild MS में, mild AS में I can also see pulses Bispherians. ठीक है? And unilateral Bispherians I can see it in dissection of the aorta. ठीक है? What about the dicrotic wave? अब dicrotic wave का मतलब ये है I'm going to see a percussion wave, that's fine. I'm going to see a tidal, I'm seeing dicrotic. Usually I see only percussion. But अभी क्या हो रहा है? Percussion is there and dicrotic is getting enlarged. And why is the dicrotic getting enlarged? It must be something to do with the peripheral vascular resistance. So one example is anything that decreases the cardiac output is going to increase your peripheral vascular resistance. ठीक है? By the baroreceptors वाला mechanism, it's going to constrict the arterioles. So what's going to happen is whenever the cardiac output is less, systolic upstroke कम होगा, normal incisura मिलेगा, तो systolic upstroke कम है, normal incisura है, but I'm going to see a very rebound dicrotic wave. Why? Because the total peripheral resistance has increased due to the decreased amount of cardiac output. So you name any cause of cardiac output का कम होना, mainly we can see a dicrotic pulse. That is one pulsation is in the systole, one pulsation in the diastole. ठीक है? So we can have your left ventricular dysfunction as one cause, congestive heart failure, cardiac tamponade, dehydration, typhoid fever, intertoxic shock. ठीक है? All of these are your symptoms. All of these are your features जहाँ पे हमारा cardiac output is going to be less. Pulses alternance when am I having is mediated in left ventricular failure. ठीक है? Left ventricular failure. What is happening? Alternating small and large volume pulses, but in a regular rhythm, and that is why pulses alternance is different from something we are going to see. ठीक है? Pulses alternance का मतलब ये है regular rhythm पे I'm seeing amplitude बढ़ रहा है कम हो रहा है, amplitude बढ़ रहा है कम हो रहा है. क्यों हो रहा है? Mainly it is left ventricular failure. ठीक है? कभी कभी कॉन्ट्रैक्ट कर पा रहे हैं लेफ्ट वेंट्रिकल अच्छे से, और अगर नहीं भी कॉन्ट्रैक्ट कर पा रहे हैं, नेक्स्ट फेज में कैल्शियम इज गोइंग टू बी मोर अवेलेबल, नाउ इज गोइंग टू कॉन्ट्रैक्ट एट अ मच हायर स्ट्रॉन्गर कॉन्ट्रैक्शन. ठीक है? सो दैट इज मेनली योर पल्सेस ऑल्टरनेट्स. मेन एग्जांपल इज लेफ्ट वेंट्रिकुलर फेलियर. ठीक है? द सेकेंड थिंग जो हमने अभी बात की थी, दैट्स योर पल्सेस बाइजेमिनाई. ठीक है? इसमें आई एम सीइंग इररेगुलर रिदम ड्यू टू अ वेंट्रिकुलर प्रीमेच्योर कॉन्ट्रैक्शन. ठीक है? और इसमें क्या हो रहा है? व्हाट इज हैपनिंग इज following a VPC. Now VPC or what? They were irregular. पहली बात. So following a VPC, what's going to happen is there's going to be a pause. I'm going to call that as a compensatory pause. हम वो arrhythmias में पढ़ेंगे. But there's going to be a pause. And whenever there's going to be a pause, I'm going to see what? I'm going to see silence in the ventricle. The ventricles will be, चलो ठीक है, I'm going to fill for a much longer amount of time. When it's going to fill for a much longer amount of time, when I'm going to see increase in diastolic filling, then that means end diastolic volume is going to increase. And what's going to happen? जो amplitude हमारा कम आया था, तब next में हमारा बढ़ जाएगा. So that is VPC के कारण, compensatory pause के कारण we are seeing pulses bigeminal. But the rhythm is irregular as compared to pulses alternance, जहाँ पे rhythm was regular, but it was only occurring due to a left ventricular dysfunction or left ventricular failure. Then I'm going to see something known as pulses paradoxes. What is happening is usually on inspiration, the systolic blood pressure falls by less than 10 millimeters of mercury. And why is that happening is कि whenever we inspire, the intrathoracic, what is going to happen is negative intrathoracic pressure is generating, and उसके कारण venous return is augmented. ठीक है? And whenever the venous return is augmented, right side का I'm saying, left side का क्या होगा? Whenever the lungs are going to expand, जो इसके lung की जो भी हमारी pulmonary veins है, they're going to expand, उनकी compliance is going to increase. and hence what's going to happen is it's going to accommodate more amount of blood without sending it to the left atrium. सारा का सारा blood will be in the lungs, not reaching the left atrium because it has already underwent an increase in the compliance. It's going to increase that. ठीक है, तो सारा का सारा blood is in the lungs and I'm seeing right का venous return is also augmented. तो उसके कारण whenever the left ventricle का venous return has decreased due to this mechanism, I'm going to see a decrease in cardiac output or basically a decrease in your systolic blood pressure, decrease in your stroke volume and decrease in your systolic blood pressure. This is normal up to 10. What I'm going to happen is something known as pulsus paradoxus, jahan pe it's not a paradox, first example, it's an exaggerated thing of a physiological response. That's the first thing. Why is it paradox is, normally it should not have happened. ठीक है, ऐसा नहीं होना चाहिए था because this is something which normally happens. But the thing is, we are having a physiologically exaggerated एक response मिल रहा है. Where can I see it? Mainly दो examples हमारे हैं, that is cardiac tamponade, ठीक है, and your constrictive pericarditis. ठीक है, उसमें what is happening in case of cardiac tamponade is, या cardiac tamponade में क्या हो रहा है? We are having increased amount of your blood, or it could be any serous effusion or whatever. We are having increased amount of fluid in your pericardial cavity. उसके कारण the heart is not going to accommodate much or less amount of blood already. ठीक है, so whenever inspiration is going to occur, ठीक है, तो what's going to happen is ये जो हमारा ventricular septum है, because the right side का venous return is increasing and the right ventricular volume is increasing, so we call this something known as interventricular dependence, जिसके कारण ये septum is going to bulge towards the left hand side and decrease इसका left ventricular stroke volume. ठीक है, so you can read more about it, but pulsus paradoxus का main जो examples are acute severe asthma, your constrictive pericarditis and your cardiac tamponade. ठीक है, all right. So let me move forward now. So now we're going to discuss something about the cardiac output. हमने already discuss किया. Cardiac output is stroke volume into your heart rate. We're going to proceed forwards. Stroke volume हमें पता है it's about 70 ml and it's mainly end diastolic volume minus your end systolic volume. End systolic volume हमने पढ़ा 120 ml and end systolic volume हमने पढ़ा that's after your 50 ml and we also calculated the ejection fraction as well. ठीक है, so that makes sense. The cardiac index we've already seen. Mainly, अगर मैं average लूँ, it's about 3.2 liters per minute per meter square. But it is a range that's about 2.8 से लेके 4.2. ठीक है, all right. What is the cardiac reserve now? Cardiac reserve is what is the cardiac output at your rest and the maximum cardiac output that can be achieved by an individual to do any exercise. That is your cardiac reserve. मतलब the cardiac output can increase up to 20 to 25 liters per minute. ठीक है, and even in trained athletes, even much more than that. So that's your cardiac reserve. ठीक है. So just see your cardiac output, when can it increase and when can it decrease mainly. So when can it increase? Mainly it can increase in your anxiety and excitement, obviously, exercise, yeah, high environmental temperature and epinephrine. And when it can be decreased, mainly in your sitting or standing from lying position, okay? Rapid arrhythmias में the cardiac output can decrease and your heart disease में obviously due to the decreased amount of stroke volume, we can have this, okay? Alright. So this is a very important thing as well. What is the distribution of the cardiac output? So let me just tell you some frequent MCQs that are here, okay? So the maximum amount of cardiac output ml per minute में जो deliver होता है to an organ is liver. First MCQ. So this is a picture can be found at your different videos over the net, but it can also be found in your Gnong as well. That's in circulation wala chapter mein. So we're going to see liver mein the maximum cardiac output is being delivered. That is about 1.5 liters per minute. It makes sense. What about the maximum cardiac output per 100 gram of an organ per minute? So यहाँ पे the answer is going to change and now it's going to become kidney. ठीक है? The arteriovenous difference maximum is in the heart and minimum is in the kidney. Again one MCQ. And last में oxygen consumption is maximum in the liver, but oxygen consumption per 100 grams per minute maximum is going to be in the heart. ठीक है? So just see that the liver में it's only the maximum amount of cardiac output is getting generated. That's about 1.5 liters of all of that cardiac output, 5 liters per minute is going to the liver. ठीक है? पर अगर हम per 100 gram of tissue की बात करेंगे, then the kidney is going to take the seat. ठीक है? Very important. What are the factors maintaining the cardiac output? First thing is heart rate and second thing is the stroke volume. हमने अभी पढ़ा that cardiac output is your heart rate into stroke volume. ठीक है? And liters per minute या ml per minute में हमें we can have this answer at 5 liters per minute. तो we can have some factors जो कि heart rate को affect करेंगे and some factors we can have stroke volume पे affect कर सकते हैं. अगर regulation of the heart is occurring due to something external, मतलब मान लो could be any hormone, could be any neural control outside the heart, then that is known as extrinsic control. Whenever it is occurring within the organ itself, then I'm going to call it as intrinsic control. That's auto-regulation. हमने auto-regulation kidney में भी पढ़ा है, हम ये auto-regulation brain में भी पढ़ सकते हैं, ठीक है? Auto-regulation मतलब that organ can regulate its own amount of whatever is going inside and outside, ठीक है? Right. So now the thing is, जो Frank-Starling mechanism है ना, that is your one example of an intrinsic regulation. मतलब Frank-Starling के accordingly, we are going to study that heart is going to increase its amount of stroke volume itself. That's a Frank-Starling mechanism. But at the cost of what? At the cost of heterometric regulation. Heterometric मतलब cardiac muscle fibers की length is going to decrease or increase. मतलब it's heterometric intrinsic control. That's a Frank-Starling mechanism. And what about homeometric or extrinsic control? Homeometric का मतलब ये है that the length is going to remain the same, but the control is going to be extrinsic. ठीक है? So let's just see one of them. We can see initial length of the muscle fiber हमने already पढ़ा था. Then we can have something known as active tension. We can have something known as passive tension. ठीक है? जब हमने curves पढ़े थे nerve muscle physiology, we discussed जो active tension होती है ना, that's going to be, and the active tension as well as your what? Your total tension is going to be maximum something known as the resting muscle length, also known as the optimal muscle length. मतलब इस muscle length में what's going to happen is यहाँ पे हमारी maximum amount of active tension generate होती थी. Passive tension कैसे generate होती है? जितना जितना मैं length increase करूँगा muscle का, passive tension is going to increase. वो stretch होएगा उतना. But that was at the cost of the active tension. So active tension का कुछ ऐसा था graph, passive tension का कुछ ऐसा था graph, and जो overlap sort of था, I would say that is at the optimal resting length. जहाँ पे मेरे active tension or total your resting tension is going to be maximum in case of your total tension. ठीक है? So we already discussed about this. So this is the resting length that I was talking about. This was the graph I was talking about. Okay, this is the passive tension. This is your active tension. And दोनों के overlap पे we're going to see this portion जहाँ पे हमारा total tension is going to be maximum. That's known as the resting length of that muscle. ठीक है? तो what is the Frank-Starling law? Frank-Starling law का मतलब ये है whenever within physiological limits, initial length of the muscle fiber is directly proportional to the force of contraction. As we can see, muscle length जितनी है, मान लो इतनी muscle length है, I'm going to generate this much amount of total tension. अगर इतनी muscle length है, I'm going to generate this much amount of total tension. So that is what is Frank-Starling law. But at what levels? At some physiological limit. एक लिमिट ऐसी आएगी जहां पे even if I increase the tension, I'm going to see a decrease in the amount of work that I'm doing. ठीक है? So it's going to be, tension is going to be directly proportional at only within a physiological limit. उसके बाद the tension might even fall. The passive tension might increase, but at least the active tension will definitely fall, as we can see. ठीक है? So this is length tension mechanism. We have already discussed about all of this. तो when I'm going to talk about first thing, हमने अभी कहा कि हार्ट रेट को हम रेगुलेट कर सकते हैं और हम कार्डियक आउटपुट को रेगुलेट कर सकते हैं. हमने फ्रैंक-स्टार्लिंग लॉ भी पढ़ लिया. हार्ट रेट को हम कैसे रेगुलेट कर सकते हैं? Either we can contribute by the autonomic nervous system and your baroreceptors. We can have something known as the Bainbridge reflex as well, जिसके it is in response to your atrial stretch. And don't forget effect of your respiration and chemoreceptors. What do I mean by effect of respiration is there is a very important thing known as sinus arrhythmia. ठीक है? Sinus arrhythmia. What is sinus arrhythmia? Arrhythmia मतलब there is an alteration in your heart rate or alteration in the rhythm. Agreed? But this is sinus. What do I mean by that? It's not pathological. It is physiological. And what am I saying physiologically is inspiration पे the heart rate is going to increase and expiration पे the heart rate is going to decrease. What about the blood pressure? Blood pressure falls on inspiration and increases on expiration. उल्टा है, ठीक है? Heart rate is going to increase in inspiration, fall in expiration. How, you might ask? Whenever we're going to have inspiration, the stretch receptors in the lung get stimulated because they're undergoing stretch, inspiration हो रहा है. And that's going to inhibit via the vagus nerve, and that's going to inhibit the cardiovagal center. That's a nucleus ambiguous and dorsal nucleus of vagus. और उसके कारण जो vagal discharge है towards the heart is going to decrease. So usually heart का क्या होता है? It's kept under vagal control, and whenever that vagal control is going to decrease, you're going to see an increase in the heart rate. ठीक है? So that is known as sinus arrhythmia. ठीक है? Heart rate regulation, we've already seen effect of heart rate on your cardiac output. हमें पता है whenever there's an increase in your heart rate, we might see an increase in the cardiac output. But heart rate का cardiac output पे क्या effect है? Whenever we're going to see increase in heart rate, obviously हमारा cardiac output can increase. But obviously हमारा जो what can happen is whenever there's an increase in heart rate, एक और चीज is getting shortened. That is your diastole. ठीक है? जब हमारा heart rate increase करता है, then I'm seeing cardiac cycle का duration should decrease. Fine. But cardiac cycle में भी proportionately अगर बात की जाए, diastolic filling is the one which is getting affected. And whenever I'm going to see a decrease in the diastolic filling, obviously I'm going to see a decrease in the stroke volume as well. ठीक है? Very important. And what is the Bowditch effect or the staircase phenomena? What is that? कि मतलब increased heart rate results in accumulation of calcium in the myocardium, and that can lead to increased force of contraction. ठीक है? So that is known as the Bowditch effect or the staircase phenomena, also known as the Treppe phenomena. ठीक है? Very important. What about the ANS control? हमें पता है under resting conditions, the parasympathetic discharge is going to be the one which is going to dominate. ठीक है? If all the autonomic nerves were blocked, the resting heart rate would increase from 70 to about 100. ठीक है? That is known as the intrinsic heart rate. ठीक है? The negative chronotropic effect हमें कैसे मिलेगा? Due to parasympathetic stimulation, and I can see a positive chronotropic effect due to sympathetic stimulation. That's one control. ठीक है? हमने already पढ़ लिया. Very importantly, we can see the parasympathetic neurons, we can see the sympathetic neurons. Just remember, cerebral cortex is the one which is going to influence the hypothalamus, and hypothalamus ये सब कुछ करा रहा है, whether the control of the autonomic nervous system. तो उसमें just remember, जो anterior nucleus है hypothalamus का, that's going to stimulate your parasympathetic neurons, and your posterolateral regions of the hypothalamus is going to stimulate your sympathetic neurons and increase your heart rate. ठीक है? Positive chronotropic effect of the sympathetic nervous system हमने already पढ़ लिया, didn't we? हमने ये पढ़ा था that we have something known as the HCN channels. What were they doing? They were completing the prepotential. And I call them HCN because they're hyperpolarization cyclic AMP gated channels. Whenever I'm going to have a beta 1 receptor का stimulation to norepinephrine or norepinephrine, what I'm going to see? I'm going to see an increase in the cyclic AMP because हमारा adrenaline cyclase in the 1 is going to get activated. Whenever I'm going to see an increase in the cyclic AMP, ये जो हमारा channel है ना, HCN channel is going to function more. And what's going to happen is, जो prepotential ऐसे जा रहा था ना, it's going to go like this. It's going to go at a much higher rate, at a much steeper rate. तो obviously हमारा heart rate is going to increase. ठीक है? So that's one thing. Can you see here? तुम्हारा जो prepotential, if you see over here, this is हमारा sympathetic stimulation and this is हमारा without the sympathetic stimulation. See इसका slope and see इसका slope. You see a hell lot of difference. And why is that difference happening? Because the prepotential जो हमारा है, that is getting completed. Why? Much faster due to the cyclic AMP जो हमें beta 1 receptors के through generate हो रहा है, that's going to lead to increased opening of your HCN channels. Does that make sense? And the negative chronotropic effect is going to be the exact opposite only. ठीक है? So we know M2 receptors are present on the heart. The M2 receptors are GI linked receptors. They're going to decrease the cyclic AMP. And the cyclic AMP अगर हमारा कम होएगा तो obviously the opposite is going to happen. ठीक है? Just remember one more thing. Beta gamma subunit of your GI linked receptors can also directly influence your potassium channel, and that can also lead to hyperpolarization. And that is one reason जिसके कारण हमारा heart rate fall कर सकता है. Let me just see you an example. देखो, यहाँ का slope देखो, यहाँ का slope देखो. This is normal, and this is the slope which has been decreased due to your parasympathetic stimulation. And I can see, I think you all guys can see कि क्या actually हो रहा है. ठीक है? So इसमें mainly हमारा जो prepotential है, that is not getting completed because हमारे HCN channels are getting inhibited right now. And what is this baroreceptor reflex that we talk about? ठीक है? Baroreceptor reflex का मतलब ये है, we have two types of baroreceptors. We can have the aortic sinus baroreceptor, we can have the carotid arch का baroreceptors. ठीक है? So whenever these baroreceptors are stimulated, aortic arch via the 10th nerve and your carotid via your 9th nerve, what they're going to do is, it's a very intricate mechanism we're going to discuss in much detail in our further class. So आज I'm going to tell you one thing कि baroreceptors का मतलब ये है, whenever I'm seeing an increase in the blood pressure, I'm going to see a decrease in the heart rate. ठीक है? मतलब blood pressure and heart rate are inversely related. And what is that law known as? That's known as Mary's law. ठीक है? So this is your baroreceptor reflex. What is the Bainbridge reflex? I talked about the Bainbridge as well. ठीक है? हमने अभी ANS बात करनी है, हमने baroreceptors की बात कर ली. अभी we are talking about the Bainbridge. Bainbridge का मतलब ये है, whenever we're going to see an increase in the blood volume, that's going to stretch the SA node, and that's going to increase the rhythmicity of the SA node. That's going to increase the heart rate. That's known as a Bainbridge reflex. Simple. Stretch right atrium. That's going to stimulate low pressure baroreceptors which are present. High pressure baroreceptors are in the carotid and your aortic sinus. ठीक है? जो हमारे लो प्रेशर baroreceptors है, they are present in the right atrium. Whenever they are going to get stretched, that's going to increase the SA-nodal discharge, and this reflex is known as the Bainbridge reflex. ठीक है? And what about the effect of respiration and chemoreceptor? हमने respiration की already बात कर ली. That's something known as a sinus arrhythmia. ठीक है? Just remember, hypoxia, acidosis, and hypercapnia are going to activate your peripheral chemoreceptors. They're going to directly stimulate the cardiovagal center. They're going to inhibit your lung stretch receptors, whether they're going to inhibit the cardiovagal centers. But mainly hypoxia, acidosis, and hypercapnia क्या कराएंगे? They're going to mediate hyperventilation. तो hyperventilation जब भी होगा, that's going to stimulate your lung stretch receptors, and that's going to inhibit your cardiovagal center. उसके कारण हमारा heart rate can further increase. Just remember, hypoxia, acidosis, and hypercapnia can also increase your heart rate. ठीक है? And we have discussed all about the effect of the heart rate. As you can see, हमने पूरा का पूरा इसमें sum up कर सकते हैं हम इसमें. Other factors भी हैं affecting the heart rate. We can see age, है ना? हमने कहा bradycardia is mainly predominant in your elderly individuals, whereas जो बच्चे हैं या फिर infants हैं, उनका heart rate is on the higher side. We can have sex differences, we can have temperature differences. Obviously, whenever the temperature is more, the heart rate is more. ठीक है? Very important. We can see drugs can mediate your increase in heart rate or decrease in heart rate. We can see hypoxia, thyrotoxicosis, है ना? Increase intracranial pressure. हमने already Cushing's reflex की बात की थी कि उसके through I'm going to increase the mean arterial pressure, but at the cost of your heart rate. ठीक है? Due to the baroreceptors. ठीक है? Emotions, pain, exercise, है ना? All of these can stimulate. Alright. So आज के लिए I'm going to end right now. ठीक है? We have basically the next thing that is left is basically your some portion of your cardiac output. जो और अभी आज we have stopped at your this portion, that is one portion of your modulation of your cardiac output. The next session we are going to discuss about the factors affecting the venous return, and then we are going to have a comparison and a summary कि क्या क्या factors थे हमारे cardiac output को वो करने के लिए, influence करने के लिए. And then later on, we're going to study about the Fick's law, and we're going to see how we're going to measure the cardiac output in practice as well, and mainly in experiments as well. And जो भी इसके associated applications हैं कि Fick's law और कहाँ पे हमने पढ़ा है और कहाँ पे हम उसे regulate कर सकते हैं. If you remember, paraaminohippuric acid का clearance is also dependent upon your Fick's law. ठीक है, बस वहाँ पे हम clearance mechanism use कर रहे हैं, वहाँ पे हम fancy term ले रहे हैं clearance, pH clearance, but basically that's also dependent upon your Fick's law only. ठीक है, तो the Fick's law as well as the cardiac output का जो remaining portions है, we're going to discuss it in the next session. And what is left actually is, I think, yeah, that is one thing that is left is your cardiovascular regulatory mechanisms. तो दो portion हमारे next session के लिए हैं. Purposefully, I have left ECG today. That is because I find कि ECG is not actually a physiological topic, because it is taught in physiology, but I think it should be correlated with the medicine. ठीक है? Because reading ECG in medicine straight away before reading the physiology is nonsense. And reading physiology only and not knowing the ECG का medicine वो तो और भी बुरी बात है. But the thing is, we need to integrate it, we need to learn it in a better sense. And ECG के लिए we're going to see some different section. I'm going to complete it in about 3-4 days आराम से. ठीक है? And for the time being, I can say if anyone is interested in cardiovascular physiology, there's a very good book that is Levick's Cardiovascular Physiology. Whenever you're not understanding anything, I think जो मेरे को जो ज़्यादा difficult जो portion लगता है मुझे in cardiovascular physiology is your hemodynamics. ठीक है? वो different laws जो हैं, that is your Pusey's law or your different हमारी equations जो होती हैं या Darcy's law है, different laws जो हैं, Reynolds number, turbulent flow, laminar flow, all of that is very beautifully given in that book. ठीक है? So I think आज के लिए it's enough. I hope that you loved this session and enjoyed it, and it was of some benefit to you. सारे के सारे tutorial notes have already uploaded in the Telegram group. You can check them. ठीक है? We're going to have a different session on your heart sounds. वहाँ पे we're going to discuss the clinical correlates of the heart sound और जो उसकी सारी abnormalities हैं, whether it be the intensity के changes or your splitting वगैरह. We're going to see separate videos of that when you're going to see cardiovascular medicine जब हम discuss करेंगे. And separate videos on murmurs as well. So that is not even a part of your physiology. ठीक है? तो अभी we are mainly limiting ourselves to your proper cardiac muscle के properties. We have already studied nerve muscle as well. आज I've revised that again with you guys as well. We discussed about the automaticity. We discussed about the electrophysiology behind it. And जो भी rest sections हैं, I purposefully left them for ECG because that will form the core concept of your ECG. ठीक है? All of those portions. Whether it be the phases of your ventricular depolarization, जिसमें हमारा septal depolarization vector है या major ventricular depolarization vector है, basal depolarization vector, I purposefully not discussed them because that discussion will be incomplete if I don't discuss ECG along with it. ठीक है? So I'm going to make the ECG slides as well. I'm going to share that as well. अभी भी I have already put it on the Telegram group. ECG का PDF is already there. You can check that out as well. But I'm going to make it much more refined and give it to you guys at a later point of time. ठीक है? So we're going to complete cardiovascular physiology tomorrow. That's going to be a last session, and then we're going to take up respiratory physiology maybe, and then उसके बाद हमारा पूरा physiology will be done. ठीक है? It sure did take a lot of time, but I hope that these sessions are helpful to you, and it's great fun for me to make as well. ठीक है? So thank you so much for attending. If there are any questions, I'm ready to entertain as well. Alright, तो आज का सेशन आई एम पुटिंग टू अ क्लोज. ठीक है? सो यू गाइज गो होम एंड स्टडी, एंड जो रेस्ट का डिस्कशन है वी कैन डू इट टुमारो. थैंक यू सो मच फॉर लिसनिंग, एंड इफ यू लाइक दिस वीडियो प्लीज गिव इट अ थम्स अप एंड शेयर इट विद योर फ्रेंड्स एज वेल. थैंक यू सो मच शुभांगी फॉर कंडक्टिंग दिस सेशन एज वेल. एंड इफ देयर आर एनी डाउट्स, कोई भी अगर डाउट्स है, यू कैन रीच अस ऑन टेलीग्राम. वी हैव अ टेलीग्राम ग्रुप एज वेल. And you can reach it on Instagram as well. So you can do that. ठीक है? Alright. Thank you for listening to me, and I'm going to close this session right now. Thank you so much.